All right. Well, thank you, everybody, for giving me this opportunity to present with you. My name is Drew Burkley. I'm a child psychologist at the Knoxville Center of Excellence for Children in State Custody. I'm also a PCIT trainer for the state of Tennessee. We'll talk more about that a little bit later. But basically, I get to go across the state and train therapists in PCIT. And I've had the wonderful opportunity to also work with Family and Children's Services on implementing PCIT. I'm excited to talk about that with you today. Also, as a quick programming note, if those just joined, I just became a foster parent last night, and there's a 19-month-old right across from me, and so she may be joining us if she gets so much, needs a little bit more loving. So I'm going to get started on this first part, and then I think I might have to grab her. So you'll see in this presentation that there's lots of great slides and wonderful-looking slides. I cannot take credit for those slides. If you see a boring slide, that's probably my slide. But I must give credit where credit is due to the creators you see on the screen, including our own Dr. Liz Pamel, and I think, John Paul used to be on there. I guess we took out his slides, but all of those there are trainers for PCIT. If you want more information about PCIT International, you can go to our website, pcit.org, and there you'll get to find a map of nationwide providers. You'll find more information about PCIT and the research, and just general information about where to find trainings and so forth. So it's a great resource with handouts and brochures and things as well. PCIT is also not invented by yours truly. Again, giving credit where it's due. That's Dr. Sheila Iberg, who started the PCIT movement back in the 1970s, training under Dr. Constance Hanft at the University of Oregon. What really made PCIT unique in this fashion is that it is hard a lot of times for good therapies to go from a research model to an implementation model. And Dr. Iberg had enough foresight and courage to kind of make this into a dissemination model where it's widely disseminated. They often call it the ivory tower effect, where researchers will come up with these fabulous methods that have 90-minute sessions and 3 times weekly. And if you're a community mental health therapist, you're saying, I don't have that, that doesn't happen. No, and that doesn't happen. But we were able to make PCIT digestible. So as a result of all of this research, PCIT is one of the most prominent evidence-based practices for worldwide for young children with disruptive behavior problems, which we love as a feather in our cap. We don't just compare this to kids who don't get treatment. We compare this to kids who get other treatments. We'll talk about that later. And it's not just us, the COEs disseminating it, or just PCIT International. This is disseminated by several different organizations, all international, that have read, studied, and trained in PCIT and are now implementing it themselves. And so it's got worldwide generalizability as well. And so I'm going to let Rahcel take over from here. And I think you have to share your own presentation, Rahcel, to do target population.
Good morning, everybody. My name is Rahcel Murphy-Norman. I am with Family and Children's Service. I'm one of the clinical supervisors with the permanency team. I'm also a board-certified art therapist, and I am currently working through how to share my screen. So let me see here. Can you all see my target population screen here? Okay, let me see if I can. Is it showing up? I can't see y'all currently, so.
It took you back to the
home screen. That's okay. We'll move forward.
Beginning, yeah.
We'll push through. All right.
Looks good, Rahcel.
Okay, thank you all. Appreciate your patience. So parent-child interaction therapy is an evidence-based intervention designed primarily for young children between the ages of 2 to 7 who exhibit disruptive behavior problems. The therapy targets both the child and the caregiver, aiming to improve the quality of the parent-child relationship to teach effective parenting skills. So key characteristics of the target population, again, typically between the ages of 2 to 7, but occasionally adaptations can be made for children slightly older, depending upon what their developmental needs are. So if you have questions, don't hesitate to reach out to us. We work closely with the COE and Dr. Burkley. We're under regular supervision, and we can make adaptations if it's appropriate for the family. Other characteristics also include behavioral issues in children with externalizing behaviors such as defiance, tantrums, aggression, noncompliance. These include both primary and secondary behaviors. And what we mean by primary is children who have intentional disruptive behaviors, who are kind of deliberately acting out to disrupt environments, usually done for attention, power, control. But PCIT can also be appropriate for secondary disruptive behaviors. So these behaviors are behavioral reactions to emotional distress, anxiety, frustration, might be related to underlying issues, including trauma exposure. We just ask that the caregiver need to have an IQ of at least 75, meaning there's no intellectual or cognitive barriers that would impede the caregiver's ability to be active and engaged in the coaching process throughout the 60-minute session. And we'll talk more about that a little later on. The therapist must be fluent in the family's primary language because this therapy utilizes active live coaching in session. It can be done with any family constellation, meaning PCIT just needs the child and a consistent caregiver, whether that's a foster parent, relative caregiver, step parent, whomever the consistent adult figure is in the child's life. It doesn't matter if there's multiple siblings in the home, other relatives. We just need the child and a consistent caregiver to be able to facilitate PCIT. Also, PCIT can be facilitated along other services, including Intercept. So disruptive behaviors are the most common reason for referral. However, PCIT can be beneficial for caregivers experiencing parenting challenges, caregivers that are struggling with inconsistent, harsh, permissive parenting styles, caregivers who are reporting or you're seeing high levels of parental stress or frustration, or lack of effective discipline or communication strategies in the home. Also, if you're working with a family and you're noticing the caregiver is repeatedly reporting concerning behaviors and symptoms that are not improving on their own, or if you have concerns there's a strong risk for the child developing delinquent behaviors as the child gets older, reach out to us because we'd really love to talk to you and support the work that you're doing with the family. What is an appropriate referral behavior, right? So there's no kid too intense for PCIT. There's nothing they've done that we can't help with. And Dr. Burkley can attest to this as he's graduated many, many families in PCIT. And I'm pretty sure he's seen all disruptive behaviors that we can categorize. So if you see, if you can see on this slide, the appropriate referral behaviors would include anything from relational problems that might include noncompliance or whining, disruptive behaviors that are more observable from the child, including lying, aggression, behavioral problems in a school setting. Difficulty following through with authority figures is also another appropriate referral behavior. Appropriate referral behaviors can also include perfectionism, anxiety, self-injurious behaviors. Again, if you have any questions at all about whether this family might benefit from PCIT, I'm gonna put my contact information and my supervisor's contact information, and that's how you'll reach out to us. And we're happy to discuss and connect you with the right resources. So typical referrals usually include reports of routine temper tantrums, non-compliance, or a caregiver reports the child doesn't listen or they're not following instructions. There may be reports of aggressive behaviors and the caregiver seeking help to manage the child's behavioral problems at home and in the public. Because PCIT improves the interaction style between the child and caregiver, the caregiver must be able to attend a 60-minute session weekly and be an active participant in this process because that's where the success lies in PCIT. It engages the adult in the child's life as the primary impetus for change. And this format helps caregivers truly own the techniques rather than just understanding them conceptually. So what makes PCIT unique among parenting training programs? All the best and most evidence-based therapies have these two factors, and they include supporting and emphasizing the necessity of positive interactions with the child and consistent limit setting. I used to have a supervisor that would routinely say there's safety and structure, right? So first, the caregiver will practice mastering how to create positive, enriching, meaningful interactions with their child while learning skills to ensure their child feels heard and valued and loved. And after these skills are mastered, caregivers will practice how to set limits with their child in a controlled, measured environment with the support of a therapist who can provide scripts on how to respond in the moment. Parents get immediate, in-the-moment feedback on their behavior and their interaction style. Which helps accelerate the learning process and reduce the chance of misapplying techniques once they leave this space. This dual focus helps build a strong emotional foundation and address behavioral issues, which is often more effective than just kind of doing one or the other, right? So PCIT is rooted in attachment theory, with the first goal being CDI, which is child-directed interaction. And CDI supports these positive parent-child interactions and improving the parent-child relationship. There's no formal discipline technique introduced in CDI. The focus is really on increasing those positive parental attention for positive child behavior. Parents learn the concept of differential social attention, or ignoring the negative and praising the positive, in CDI. The next phase, PDI, is based on behavioral theory, and this is centered on a very structured and consistent timeout procedure. PDI really builds on CDI because we continue to use the power of the parent's attention to shape positive child behavior. One of the unique aspects of PCIT compared to other parenting programs is that discipline in PCIT relies on parent attention, parent and caregiver attention only. No material rewards or punishments. And in CDI, the child has had the experience of the most rewarding gift of all, which is the parent's caregiver and attention and focus. And this is the driving motivator for modifying behaviors in the child, ensuring we have follow through with expectations from the caregiver. So PCIT is designed for young children who are exhibiting disruptive behaviors, and for caregivers who are open to learning and practicing new parenting techniques. The therapy focuses on enhancing the parent-child bond while promoting more consistent, positive discipline strategies. Its structured, coaching-based approach makes it highly effective for improving behaviors and reducing family stress.
And I'm going to pick up here, and we're going to run through that real quick. Come on, keep going. You can do it. I know, gato. All right, so one of the things that makes PCT really unique and helpful in parenting programs is this idea of coaching. And a lot of therapies that you have out there, right? We have the therapist meeting with the kid, and that happens in play therapy. That happens in a lot of CBT. It's just the therapist and the kid meeting. In PCIT, what I like to say is we make the parent the therapist, or we make them therapeutic anyway, and that they are the main institute of change in the child. So we're changing those interaction patterns. And we do that through this coaching method. And so and I'll show you a little example of what it looks like here in a second, but this allows me to help immediately correct errors from the parent, help praise their appropriate behaviors, help give them ideas on what to say, and link what they're doing with their kid's behavior. So I might say something like, hey, did you notice when you repeated back what he said, he's talking more to you? Or as you describe what he's doing this. Or when you said that, this happens. It helps me link the skills that we're teaching them with the outcome that they get, which is really unique in all the therapies that we offer in the spectrum here of therapeutic modalities. So it's very much shaping the parent's behavior, and the parent is shaping the kid's behavior. And so this is what a coaching setup might look like. Yeah. You have a one-way mirror with a therapist there on the right. His therapist is behind a one-way mirror, and a very, very old, you can see this is a dated slide. A lot of us now are using webcams and video monitors to do this coaching modality. But anyway, that's why we were really set up for telehealth, is we can do this virtually pretty easily, since a lot of the interaction is remotely with the parent having a little earpiece in their ear, and the therapist is out of the playroom coaching the parent through that earpiece, saying things. So the therapist can see the parent, can hear the parent, and then the child and the parent are in a room by themselves outside of the therapist's purview, playing, interacting, and having fun. And so that really intensifies the relationship and bonding that the parent and the kid have. And so we do this with foster parents, but we also do this with bio parents who are having visitation with their kids, because this helps the parent know what to do and how to play with a kid from 2 to 7, and help get their attention, build that attachment up, and so forth. And so the CDI portion of this is pretty much good for almost anybody. The PDI portion we tend not to do with foster parent or with biological parents who don't have custody of their kiddos, because that involves discipline and learning, and with only once a week or once every other week visitation, we don't get a lot of that. But foster parents, again, any other constellation where there's a consistent caregiver, yes. So that's kind of what a PCIT room looks like, and logistically. And as I said, what the beauty of this all is I'm restructuring an interaction pattern. I'm not targeting a behavior to be reduced or increased or one single thing. I am changing on a fundamental level the way the parent and the kid relate. And we do this through teaching the parent skills and then coaching them through that so that they do this. We have them use these skills at home for a few minutes each day. And so for just 5 minutes each day, the parent and the kid are playing and using these skills together. And so this helps increase child compliance because the kid wants to listen to the parent because they have a good relationship with the parent, and it helps the parent get that ooey gooey Brady Bunch feeling back with the kid, that they enjoy having the kid. I often say PCIT is for parents that love their kids but don't always like them, because those pesky behaviors can get in the way of building a solid relationship. And I realize my camera's been off. There we go. Now it's easy to see me. All right. Having that relationship and use it to the parent's advantage is the way we frame it. We never frame that the parent, oh, I'm a fancy therapist, I'm going to tell you how to have a good relationship with your kid. PCIT is very positively focused. Instead of telling the parent what we're doing wrong, we are helping the parent do more of what they're doing right. And I promise you, even your parents who may see stone-faced in a kid and not have any clue what they're doing, if you give me 5 minutes watching them, I bet you I can point out 2 or 3 things that parent's doing right. There may be a whole host of other things we need to work on, but I bet there's a couple things I can pull out and amplify that parent's doing right. And we'll learn some more things along the way. But I never want a parent to think that I'm here to tell you how to have a relationship with your kid, or I'm here to tell you here to parent, or that you don't have a good relationship. And me, the expert, the stuffy therapist, is going to tell you. But all of this helps decrease the caregiver stress and helps gains maintain. Again, because I'm changing the interaction style. And once the parents know the spirit of the interaction, they can apply it to lots of different situations. So why do I like PCIT much, and how do I know that it works? Well, we are always assessing data, which is I'm not just asking the parent how things are doing. I'm giving them structured assessments. I'm observing their interactions without my intervention every single day or every single week that they're with me. And so it's never going too far outside, never going like I just take their word for it. And so this helps me understand when they've grasped enough of the skills to move to the second portion. And so this also helps us understand their intensity of behavior each week, and I get to show them the progress. Truly, week by week, after about 3 or 4 sessions, we tend to see some great improvements here. This helps them get coached independently and doing this model independently and handling the kids' behavior independently. So treatment is usually going to be about 16 to 20 sessions. In all technicality, treatment could take 8 weeks. But that's assuming the parent is a unicorn superstar parent, and I've done a great job, fantabulous job of teaching them the skills and everything, and that's not always the case on my end. I am human as well. So we make the reason why the session length varies is we don't stop until the parent's getting it right. Now, I'm not sitting there banging my head against a brick wall hoping the parent gets this. We modify, tailor, and adapt as necessary to help the parent gain the skills. But also, I want to make sure I'm taking the parent's time and going at their pace so that they get it and can use it in a variety of settings. And so we go until the parent meets graduation, which is one of the great ways that we get such good scientific support. There is really, really good research, and I'm going to bore you a little bit with the stats because lots of people have stats out there. Oh, we reduce this by this amount, or oh, hey, we do this by that amount. But it's not just when I'm comparing this to kids who don't do anything, or just saying, oh, it's this fundamentally on a mental health level and a parent stress level on real outcome measures that affect the parents' stress level and the kids' actual observations and reports of their disruptive behaviors. We are great. We are really good. It generalizes to siblings. It generalizes to home and school. It reduces non-compliance. And in addition, we also have a lot of the research and evidence to back up that we do the things the other therapies do, as far as reducing recidivism and re-abuse in indicated parents, which is great for prevention. Because we have discipline, non-corporal discipline strategies that we have the parent employ that really get the good kid to listen. You'll hear parents say, this kid just needs a good spanking. No. I've got something better. I've got something so much better, and I know it works because I've got the data to back it up. And I will absolutely admit there are times where I have a kid, I was like, ooh, is PCID going to work here? This is, oof. And time and time and time again, I am proven wrong by my doubts, is that this method does great things for our youngest kiddos that are the hardest to work with. So the caregivers get great outcomes from it as well, as far as they're reducing their stress. As you may be aware, those on this call, is that this is part of the Families First Prevention and Services Act. And it does it was one of the first few ones approved right out the gate. We were right up there getting approved to be a well-supported treatment. It's also supported by the Kaufman's Best Practices Project. Now, when we talk about it being an evidence-supported treatment for children with abusive trauma, it's one of the 2 well-supported and efficacious treatments for child abuse, okay? Reducing the recidivism, not just reports, right? Not just that we think this is actual parents being abusive, right? It absolutely reduces that, and I've got the numbers to back it up. So here's the not impressive research. This does not impress. Pull a little Shania Twain here. That don't impress me much. No. Why? Because when you go to waitlist controls, so this is PCIT against waitlist, anybody's going to do better against waitlist, everybody. You have a kid and a parent just sitting down with somebody talking about parent stuff, they're going to do better than waitlist. This does not impress me. No. All right, but when you see the kids that don't get treatment versus kids that do, top notch. This is the part that improves me a little bit. So when we compare this to other treatments, I'm going to give you a little bit of a thing here. And the guidance is still out there, right, that we take baby aspirin for people at risk for heart attacks because that can reduce the effects of heart attacks, right? Absolutely. You buy aspirin 86 or baby aspirin, that reduces your risk of heart attack. It helps out so much that when they were doing that study, they stopped it midway because it was unethical to not give people this treatment that could potentially save their life.
Well, that was just a question. I don't know.
Okay. And then looking at stimulant medications. Stimulants have what they call a 0.9 effect size. And you get great results out of stimulants. Parents like stimulants. I give this kid a pill, they instantly listen better. This is great. I hear you. That's a 0.9 effect size, which is large. And then we get to a 1.43, which is huge. Statistics, if you're a statistics nerd, you're like saying, I didn't think that was possible. It is possible. It is very possible. Hey, sweetie. Yeah. You'll be impressed by my research too? Yeah, big numbers, huh? Big numbers. All the big numbers. I feel like saying when I've got kiddos here, oh, thank you for pushing that forward. I'm not just the president, if you will, but I'm also a member. I've used my own kids. So fancy schmancy research looks great when you're in a clinical setting and pay the parents to show up and you've got students who are really, really determined to show their mentor and advisor they can do this, and there's great motivation, and then you get to community mental health. All right. So the second rung on my tier here is community mental health, which is an effect size of 0.7. And this is anybody who has attended at least 2 treatment sessions with PCIT, just 2, because dropouts happen. Those who graduate, we still have a fabulous effect size. Excellent for those who graduate. That's kind of because we cheat, because remember, we don't stop till the kid gets better, so we're going to have great numbers. And we do. We get lots of parents to graduation. But when we have people that drop out, I take rest in knowing that even though I've only spent 2 sessions with this family, with this kiddo, at the end of it, they're already doing better than people who complete other treatments. Let that soak in for a minute. We compare this to other treatments, other modalities, people who are getting evidence and giving great presentations about how awesome their therapy is. My dropouts do better than their completers. Time and time again. They did that in Oregon, and we did the same study here in Tennessee. Same exact one across the community mental health agencies in Tennessee with dropouts. And I still had a 0.7 effect size. Just a little bit less than stimulants, but a whole lot better than the aspirin medications. We still get good results compared to other treatments. This is what impresses me. This is why I'm so gung-ho about it. Because it's just not, we're not doing, comparing this to somebody who doesn't get anything. Yes, people always get better. In fact, it's so routine now that we have to We don't compare to wait list anymore in the literature. We have to compare to something called treatment as usual, which is they're seeing a therapist. Well, compare that to just seeing a therapist. How do we do? And again, mine do better. So that's why I say I know it works. And I will wear that feather and brag about it all day long and twice on Sundays. Whoopsie. Oh no. We've got remotes and they're fun. So the gains also that we are impressed with maintain. They maintain for up to 6 years. Now, 6 years may seem like an arbitrary number, and you may say, "Well, Dr. Burkley, why is it just 6 years?" That's because it's just when they stopped looking into it. They just stopped the treatment. That was the longest they put for their grant to study treatment effects afterwards. And so if you've got like a 6-year-old and they go through PCIT, these gains maintain till they're 12. The modality and the implementation the parents use, where'd you go, girl? There you are, are different, but because we're changing an interaction style and not just sniping a behavior or taking care of a single behavior, because I'm changing interaction, the parents can apply it to different situations as the kid grows older. That's again the benefit of PCIT. We teach and change an interaction style. So who else is this effective with, you may be asking? Lots of different populations. Give me your kids that have disruptive behavior disorders. Give me your kids who have intellectual disabilities. Give me your kids with developmental disabilities. Give me your kids on the spectrum. Give me the worst possible 2 to 7-year-old you've ever seen. I know, honey. The worst possible, most intense behavior from 2 to 7. Kids that are biting, punching holes in walls. Punching the holes in the wall. Can't go outside. I had a true story. I had a kid that the parent came to me upset. The kid went down, was in Walmart and ran their hand down the pickle aisle jar and knocked all the pickles jars off the aisle in the Walmart. And they're 6 years old. What am I going to do with this, Dr. Burkley? I says, I got something good for you. And I did. Give me that kid. Give me the kid who pulls the fire extinguisher and sprays it all over the room. Give me that kid. I got you. I got something good for you. Really good. So there is no kid too intense for PCIT. We've done this with military families. We've done this with telehealth. We do this with foster parents. There's even a modification for teacher-child interaction therapy for when the kiddo doesn't have much issues at home, but maybe some more issues at school. That is not a part of our main implementation. That just got absorbed by PCIT International, and we're looking forward to disseminating it. But that's something more in progress. But there are pockets of it being done throughout the U.S. We do this with motivational interviewing. We do this with separation anxiety disorder as well. So lots of different comorbid disorders. 2 to 7, anybody 2 to 7, I tell you truly, they will benefit from this. Now, anxiety, if we got phobia, that may do more to very traditional CBT. But for any kind of disruptive behavior, 2 to 7, we're good. Separation anxiety, we're good. All right. And yes, PCIT reduces physical abuse compared with parents assigned to a standard community group. Comparing this not just to waitlist controls, not just to people who didn't get anything, but to people who got other interventions. All right. Compared to other interventions. That's where always the golden ticket is. What's this compared to other interventions? And again, compared to community mental parenting groups, PCIT got fewer dropouts as well. So people maintain with us because they see the gains, which is why we assess every session. I have them fill out a form for me to see how the disruptive behavior is going. And every week we get to show them that graph and they get to see the change every week. It's not always a linear drop. But when we look at where the kid comes at me and when they're coming 4 sessions later, I say, hey, this was a tough week, but look, you've dropped like a tank on this measure. And they're like, oh, yeah, because it's hard to see gains sometimes when you're in the thick of it. It's like my kids never grow, by the way. I've never seen them grow. I just see them every week. They came out this big, I think. No, they didn't. But it's hard when you see take a month, they see the change. It's a little harder for me. All right. So, and again, prevention for child abuse and randomized control trial, we did better in terms of better child maltreatment outcomes. We decreased stress, reported better child behavior, and this is a study back down in 2011. And so that last point there, just reductions in child abuse potential and improvements, because we teach a non-corporal discipline style for the parent to use, and they literally memorize a script for me. Like when the kid does not listen to them, they don't have to think when they're angry. Has anybody ever here been grounded for life? You ever been grounded for life? Anybody say, yeah? Or is it just me? I was that bad of a kid. You got grounded for life because your parents were so ticked off at you, they couldn't think of what to do. Parents don't think well when they're angry. I don't think well when I'm angry. But if I've got something that you're going to say every time, and you memorize this script and we do it every time, we have consistency and predictability, and you know what to do even when you're angry, and it is effective. That's, again, the beauty of it. I don't have to have the parents think of what to do. They know what to do because we problem solved it. Well, I think you're ready for a nap, girly. She's trying to get into my mixing bowl cupboard. All right. Since I was told I could go a little bit longer, I'm going to go a little bit longer. So PCIT is a very structured thing. I'm a regional trainer for PCIT, so I'm that teal, greenish thing. My wife could tell you what color that is. I'm a loss. But anyway, and so I get to train there. I get to train trainers and I get to train therapists. And we've, as Rahcel had mentioned earlier, we've worked very closely with FCS. They've been wonderful to host most of our middle trainings over there at one point or another. And so we have therapists all out in the community, all over the place. At the COEs, we have done a ton of dissemination. We've trained over 300. I just did the numbers yesterday for you all. We have trained approximately about 362 therapists in Tennessee since 2011. Since 2014, we've trained 320 since 2014, and 80 of those in the past 2 years. And that's a lot. Like when we had the PCIT International Convention here in Knoxville. Oops, hey baby, wrong way. We're going to go this way. The PCIT International Convention here in Knoxville. And when I told them our numbers of training, they're like, "Oh, what? Yes, we are training machines and we're good at it." So we have agency trainers that help keep the enthusiasm for PCIT, and are a torch holder for it at the agency. Here, we'll push this button. Push. And this is a map. There's a QR code to my map here, but this is where we've trained in Tennessee. All over the place. Each one of those dots is a place that we've trained PCIT, and about 90% of those dots take TennCare. And we are ever expanding. I have not put the most recent cohort in it, but that QR code is like a permanent link to it. And anytime I update the map, you will absolutely see those updates on there. I'm about to wrap up the PCIT portion of this, and I was going to open this up for questions real quick before we get into some FPSA parts of it. Any questions about PCIT implementation, cases, where to go? Actually, don't hold the questions for where to go, because we're going to talk about that in just a minute. All right, in that case, I'm going to turn this over to our friends at FCS to take it from there.
Yes, thank you so much, Dr. Burkley. I put our permanency referral form in the chat box, and my email, and also Julie Flannery, who's the Director of Child and Family Welfare. If you have any questions, or you have a family you're working with, you'd like to learn more about PCIT, just feel free to reach out. There's a little box on the referral form you can check for PCIT or other services. And we have Sarah McCormick with us today. She's the Director of what do? You do so many things, Sarah. Director of Training and Staff Development. But she's going to provide an overview of all of the programs we have at FCS, because the majority of the clients and families we serve, they're not just receiving one service from us. And as you all know, it's not typically just the primary client or the referral client that might need some support. There's often other family members in the home, or they might need access to health care, or might need some clinical case management support, whether that's through workforce development or housing. So Sarah's going to provide a little bit of an overview on other services we provide at Family and Children's Service, because you might have a PCIT referral and there might be other family members in the home that could benefit from the programs we have to offer, or you might be working with another family that might not need PCIT, but we might have another program there available for you. So I will pass it over to Sarah.
I do see a question in the chat about PCIT, if we have time to answer that before we move on. Just wanted to.
I don't know if Andrew's still on, but I don't know which one of you all could answer it, but they're asking, could you speak a little on how using PCIT can benefit the frontline professionals in aiding them in their work?
Absolutely. Yes. I mean, it really comes down to what can we do to alleviate the stress in the home, whether that's through relational conflict or ruptures, or the parents struggling, they might be the caregiver or parent might be struggling with the child that's exhibiting disruptive behaviors. You might be hearing that the caregiver is receiving a lot of reports from school about whether that's non-compliance or kind of acting out behaviors, or you're noticing the families really struggling with workforce development or finding employment somewhere, or not having access or resources around financial stability, and they're also struggling with just kind of parental ruptures in the home. So the hope is that PCIT can be a therapeutic modality that really helps to reduce that stress in the home. So there's less rupture and friction between the caregiver and parents. And PCIT is the focus of PCIT is really designed to help support those positive parental interactions with your child, so we can really support those strong, healthy, secure attachments in the home, so we can support permanency and less likelihood of ruptures and permanency. I hope that answers the question.
Sorry. Hey, Rachel, y'all. Sorry, this is Raymond. And it does. I guess I'm trying to, for the sake of having been frontline for God knows all my donkey years at DCS, is trying to get frontline to kind of understand that if they're using PCIT, how that helps them in the long run by not, one, getting families back because they've received the correct amount of dosage of services. It alleviates the stress for them, because then once you put that family in PCIT, you're doing more maintenance work and more supportive role to support the therapist and the work that they're doing in PCIT. So I was just kind of looking at, from a worker's perspective, how, if I'm using this, how does that decrease my overall stress as a worker, my overall work as a worker?
That is so great. Thank you so much, Raymond. And I'm glad you're here.
So I suppose I'm not sure if there was an answer to that. I had my little girl here has got superpowers. With one swipe of a button, she closed my entire browser window. So they have that superpower. As a frontline worker, reducing your stress is, I think you actually summed up, Raymond, right? Is that you don't have to. There's not going to be as many reports, or not much for you to do, but you can still be helpful, by the way. If you're talking with the parents, they've got them in PCIT, asking them if they're doing their homework, which is they're doing this 5 minutes a day with their kid at home. If they have multiple kids in the home, having them sit down, the frontline worker can sit with the older kiddos for just 5 minutes while the parent works with the younger kid to do special playtime. That's a fabulous thing too. Those are things and ways that frontline workers can help out the PCIT therapist, is just checking up to and reducing barriers as well to them doing the homework. Sometimes it can be, I have to watch these other kids, or I've got nothing further ones to do, or I need to find a time to do it, or I don't have a place to do it. Be an active problem solver with the parent and help them find a place that they can do this, or get them the toys that they need to do this. We don't take for granted that not all our parents might have access to the toys that make PCIT successful. And so those are ways that the frontline can help out. But again, there's not going to be as many stressful calls because the parent's going to know what to do when situations arise. And they're always welcome to call the therapist in between sessions, and we can help guide on how to implement certain things. The discipline portion has different modalities we use when we generalize it to house rules, and then also taking the kid in the community. So I hope that's helpful information.
All right. Well, I will take over then. So as Rachel mentioned, I'm the Director of Training and Staff Development here at Family and Children's Service. And we just want to make sure that you are aware of our programs and how to connect families to our programs to best support you. So I will now try to share my screen. Let's see. All right, and I cannot see you all anymore. So if anyone can tell me, can you see my screen?
Yes, we can.
Yes, we can.
Okay, perfect. All right. So again, Family and Children's Service, we've been around for over 80 years, and we have a lot of different programs that you may be aware of that you weren't aware were a part of our agency. That happens a lot, which is totally fine as long as people are getting the connections they need. We're happy about that. But again, just kind of want to provide a broad overview of our programs today. Our mission is to connect individuals and families to hope, to healing, and to one another, and really to just kind of stand in those gaps where traditional services might not be covering. Our first kind of bucket that we're going to talk about is traditional counseling services. And so we have a wide range of therapists, some who are trained in PCIT, some who are not, but providing those traditional counseling services for the community completely free, most of the time in person, sometimes telehealth. Our main location is here in Nashville, and we do co-locate counselors and other nonprofits around the area just to decrease barriers, be closer to clients, and be hopefully in spaces where they're already interacting. So again, this is just traditional services. We do have some bilingual therapists as well. And at the bottom of each slide, there should be a way to get connected. So as you can see, there's an email that you can refer, or also a referral form on our website. Family-focused solutions is also a type of counseling and case management service, but this is specifically for families that are interacting with Families First or TANF. So just a niche population, and working with those families to get them the support that they need. And so obviously a very specific group of clients that we're working with there. And of course, working alongside you all, partnering with DCS and case managers. And so you can refer directly to FFS through that, or you can call us and we'll get you connected. We always say there's truly no wrong door approach. Everyone at the agency really has that mindset of, if you connect with someone, we're going to get you where you need to be. So truly no wrong door, we'll get you there. The Crisis Contact Center. So we do answer phone calls for the 988 National Suicide Prevention Crisis Line, and those texts as well, and also the Tennessee Red Line. So again, that is 24/7. All of those crisis contact centers, they're fully remote at home. And again, just a great resource for you all to be aware of, as I'm sure you are. I will shamelessly plug this one because this falls under my area. So this is one of our newer programs, mental health awareness training. So this is really for you all as professionals, and we provide evidence-based trainings completely free, and we will come to you and make it super easy. So right now we provide QPR, which is 1 hour, and that one can be done virtual or in person. And then mental health first aid for adults and for youth, and those both need to be done in person. They can be done in a 1 8-hour session or split into 2 4-hour sessions. So a little bit more of a time commitment, but really, really valuable information about de-escalation, crisis referrals, and just providing suicide prevention as well. And so Brittany is an amazing trainer with the agency. She worked on the crisis line for 4 years and now does all of those trainings in the community. So again, we would love to support you and your staff if that's something you're looking for. Survivors of suicide loss, recognizing that people that have had a loved one die by suicide are more at risk to experience suicidal ideation themselves. And so just creating a support group for them and a place for them to get together. And this is truly, you can come one time, you can come multiple times, there's no limit. But we do have a referral line right there, the phone number to get connected with that group. Connecting Forward is one of our newer programs, and they're doing great work. They are spread across Tennessee, and really kind of, like I mentioned before, just trying to be where families already are and create a more seamless process to getting them connected with services. So you can see here, workforce, employment, mental health, really just wraparound case management to really get families connected and supported. And there is an email that you can call, or a phone number as well. And they're doing really great work and have already served a lot of Tennesseans through that program. I think we're entering year 2, so super exciting work. relative caregiver program, exactly what it sounds like, and just really supporting new caregivers that are taking in a family member and supporting them, supporting the child, and just really wraparound services and counseling to make sure that there's no further disruption and getting them the support that they need. So again, we've got a phone number and email for you at the bottom of the slide and the counties that we're listed in. Community schools. This is my background. I was working in our community schools program at an elementary school in East Nashville before stepping into this role. So also really love this program. Currently, we're in about 20 schools just in Metro Nashville. And it's really a one-stop shop, again, meeting families where they are. Students are in school 8 hours a day, and really just, it's almost a mini nonprofit within the school is how we describe it, and just meeting basic needs and bringing in community partners and just really getting to get enmeshed in the school community because we're there 5 days a week. And so that's a really great program. And if you're working with families in the schools, likely there's one of us represented there if they're in Metro Nashville, and so would love to get them connected as well. And again, you can just call us and we'll see how we can support. Child welfare and permanency. So we have Wendy's Wonderful Kids, which is one of our smaller programs that are doing some really niche on the ground work, looking creative ways to place foster children who are about to age out, and really just creatively looking how can we get them connected with possibly a family, and doing almost kind of like a needs assessment and looking at gaps and figuring out how we can support them. Child and family permanency support, again, just trying to keep families together, case management and counseling, and working specifically in Davidson County. And I think that is where PCIT possibly falls under as well. And then Get Covered Tennessee. So if you have a family that is needing connection with insurance, we would love to work with them and have some really great navigators who can provide completely free and unbiased assistance to get them connected with the best plan for them and their family. And there's a whole tab on our website where they can book directly either an in-person appointment or a virtual appointment. And then this is our only fee-based service. So we do contract with, say, a community clinic. If they know that they are going to be needing language services, we can provide an interpreter either in person or telehealth, and the fee would be absorbed by the clinic, not by the client. And so happy to provide those services if that's something you all would need. And I think that is it. So lots of information for you all. All of that is pretty much listed on the website. But again, just want to make sure that you all are aware of these resources and how we can support you, and whether that's a training that we come to do for your staff or a referral for a family that you're working with, just want to support you all. So if there are any questions, I know that was kind of rapid fire, high overview.
As of right now, we don't have anything in the chat box. Rachel says, thank you so much, Sarah. And there was a comment in reference to the information provided on I'm saying it wrong, PCIT, from Tracy about that being a great source for prevention. Does anyone have any questions for any of the information that was presented on today? Okay.
I guess I will just add, since this is a service that is going to go through the FFPSA, for once you do your referral to the provider, you will also do the referral to the state agency, which is the federal programs office. So they will also need to receive the referral. I can put the referral form in the chat for anybody that needs it.
Please do.
As well as a map. So due to the realignment, they changed who the person is for Mid-State now. So it's Anthony instead of Takasia. I did invite them both, but they both had something else going on today. But they did send me this information to share with you. So I'm going to put that in the chat just so that you have that. And you can refer to that. When you make your referrals, you'll just need to include all the information on this form. And we will probably plan to do a training on this specifically for those that need to know the whole process, since we won't have time to get into that all today. But we will cover this in depth at a later time as far as the process in making these referrals. Sorry, I'm trying to talk and hunt for a map at the same time. So putting those in the chat now. The first one is the referral form. You just want to make sure that the child is eligible for the Title E funds, so that they are either at an imminent risk of entering foster care, or they are pregnant or parenting a youth, and that you also have that FAST completed, or a CFTM held, and an NCPP. So you would have to have your non-custodial permanency plan, and then everything entered for that referral to go through to the federal programs office. So if you look at the map, you'll see Anthony's contact information on there of where to send that to. It's also at the bottom of the referral form. So check those out if you are DCS making those referrals. And if you have any questions, you can also reach out to me about that process. Or if you have a case that you want to see, like, hey, is this appropriate for PCIT? You can get with me and I can help you walk through that process as well. But just want to thank our presenters for doing an awesome job covering the topic today, and for Family and Children's Services for being our provider. Since they do not bill insurance, you will definitely need to make sure that this referral goes through FFPSA so that it can be covered. And, just they're ready and willing. I think they said they have 3 therapists on staff that can take PCIT referrals. So if you have any other questions, please reach out to Rahcel or Julie Flannery, and they'll be happy to help you with any other questions that you have. But thank you so much for being a part of today's training.
Thank you all again on behalf of myself and Serena, who's on with statewide training. I have included the subject matter expert training evaluation form, whether you need it in QR code. I'll also drop a hyperlink for a form stack. If you all could please complete that for us today to do your evaluation and receive credit. And we have about 7 more minutes. Do we have any other questions that you all thought of before we release these wonderful presenters that we had today? It was great information. Thank you, Serena. Well, thank you all so much for joining us. If you have completed your evaluation, have a wonderful rest of your day and a great short week.
Thank you all.
Bye-bye.
Thanks.
Thank you.
Thanks, Drew.
Oh, there's the delete button.
Well, looks like everybody else hopped off. So. All right. Well, thanks. Nice to meet you.